Morning. We are having yet another episode of web learning. Today we are going to have some lectures on hair disorders. And I think hair is a very important area as far as the dermatologist is concerned. Now the hair disorder has transformed into a specialty. The trichology is there in dermatological parlance, very much there. And there are many people who are specializing in trichology. One such person is Dr. Abel, the other person is Dr. Murugusundram. Dr. Abel is Professor of Dermatology in Amala Institute of Medical Sciences, and he has special interest in trichology, and he is running a clinic of trichology, hair and disorders in Amala Institute of Medical Sciences, and he is very much interested in trichoscopy. And so with this vast experience, he has a lot of things to say, and we eagerly waiting for his talk. Over to you, Dr. Abel.
Thank you, Dr. Crichton, for those beautiful words, and I think the other speaker may join in after some time. Dr. Murugusundram will join in after some time. And today, what we are going to discuss is about hair disorders, and my topic is just an overview of all the hair disorders. Hair plays a very significant role in our appearance and our identity. And whenever there is a hair disorder, what happens is the person becomes less confident. He loses his identity or dignity. His self-esteem has come down. Sometimes these people even go in for depression, and they don't want to go out to social gatherings and things like that. So I will be just giving you an overview of all the hair disorders. Along with that, I will be touching a little bit on the hair shaft disorders. Now, what are the concerns of the patient? What are the concerns that the patients come to a trichologist or a dermatologist regarding hair and scalp disorders? The main chunk of diseases or the problems that these people come to us is hair loss leading to alopecia. So that is the main thing. Other than that, they can come with hair shaft abnormalities. They come with increased hair growth, especially females with increased hair growth, hair color changes like hair graying and other color changes of the hair, and especially dermatoses of the scalp. We have lots of people coming with dermatoses of the scalp. Scalp itch is another condition that people come to us. They may not have any lesions at all, but they have scalp itch. And of course, cosmetic concerns. Lot of cosmetic concerns about the hair. The trend is coming up, like people want to get advice on which shampoo and which conditioner and all those things. Now, coming to the hair loss disorders leading on to alopecia. I know there is a session coming up after this by Dr. Murugusundram on hair loss itself. So I'll just a brief outline on the hair loss, just introduction to that. Hair loss disorders mainly can be classified into diffuse, patterned, and focal alopecia, and also into cicatricial and non-cicatricial. And these cicatricial alopecia or the scarring alopecias are conditions where the hair stem apparatus is destroyed. And because of the destruction, the hair is not capable of regenerating any hair after that. So once there is a cicatricial alopecia, the patient will not be able to get hair back again. In the non-cicatricial type of alopecias, the hair stem apparatus is not destroyed, hence he can regenerate hair after that also. Now, the next set of disorders is hair disorders. Here, what we have is two types of diseases. One is hypertrichosis and the other is hirsutism. Hypertrichosis is a generalized sort of hair growth wherein there is excess hair growth depending for that age, for the sex, and for the race. So certain race people may have increased hair, and that is the norm for them. And it usually occurs, and the terminal hairs and the lanugo hairs may be involved in this. And the thing is, it is not androgen dependent. Coming to hirsutism, what is hirsutism? Hirsutism is male pattern hair growth, especially the terminal hair growth occurring in women. So whenever there is terminal hair growth in a male pattern in a female, it is called hirsutism. And this is definitely androgen dependent. Now, what are the causes for this hypertrichosis? Hypertrichosis, I told you, is not androgen dependent, can occur anywhere on the body, and there are localized forms, there are also generalized forms. In the localized form, as you can see in the picture there, you can see a person having auricular hypertrichosis. Similarly, you can have hypertrichosis on the eyebrows, the nasal tip hypertrichosis. You have fawn tail, which is a bunch of hair on the sacral or the lumbosacral area. And you also have increased hair growth in melanocytic nevus, Becker's nevus, porphyrias, dystrophic EB, and also after IPL, intense pulse light therapy for hirsutism. Because of that, of the suboptimal dose of the light, you get increased hair growth, and this is called as paradoxical hypertrichosis. Often we see patients coming after a plaster cast put on them for a fracture. Now, once the plaster cast is removed, you see hair growth in that limb which was plastered. So these are all localized forms of hypertrichosis. You also have the generalized form of hypertrichosis, which could be congenitally or genetically or hereditarily. These patients have increased hair growth all over the body. That is congenital. And you can have congenital terminal hair growth, that is. And you can also have terminal hair growth due to drugs like minoxidil, cyclosporin, PUA therapy, and steroids can also produce generalized hypertrichosis. Lanugo hairs, especially the congenital hypotrichosis lanuginosa, which can occur in infants, and they have this downy sort of hair on the face and body, etc. And also you have the acquired form of hypertrichosis lanuginosa, and these acquired forms especially can be a sign of internal malignancy, and you should be looking for malignancy. It can occur also in AIDS patients, can also occur in malnutrition. This is a patient of hirsutism, a female. Look at the appearance itself. Just because of the terminal hair growth in a male pattern, it looks like a male itself. And causes of hirsutism can be familial, they may be idiopathic, along with polycystic ovarian syndrome, ovarian tumors, adrenal tumors, congenital adrenal hyperplasias, pituitary adenomas, and also with on patients with taking anabolic steroids. So all these can produce androgen-induced hypertrichosis, that is hirsutism. Now coming to the disorders of hair color. Hair color disorders can be congenital as well as hereditary. In the congenital type, you could have hair loss which could be global, that is all over wherever there is hair, the patient has white hair, and that occurs in conditions like oculocutaneous albinism, Shediac-Higashi syndrome, Menke syndrome, and the early or premature aging syndromes like progeria and Werner syndrome. It can also occur as focal areas of depigmentation in Waardenburg syndrome and piebaldism also. Now coming to the acquired forms of color changes of the hair, it can occur in conditions like, which can be global, in conditions like canitis, which is early graying of hair, which is very, very common. You could have drug-induced with drugs like imatinib, antimalarials, ipilimumab, and things and drugs like that. And also nutritional deficiency, where you can get color changes. You can get light-colored hairs, or you can also have this xanthotrichosis, where you have these yellowish orange sort of hairs. Then the other is the focal. Focal you see in vitiligo, where you have leukotrichosis in vitiligo, focal areas of depigmented hairs inside the vitiligo patch. And you can also have depigmented hairs in alopecia areata, which is recovering. And those are the localized forms of color changes or depigmented hairs. Of course, the dermatosis on the scalp, very common. Many people come to us with psoriasis, seborrheic dermatitis, tinea capitis, folliculitis, LPP, all those things. People come to us, and we are all experts in treating these conditions. Scalp itch is a very problematic condition. Occasionally, we have patients who come with just scalp itch, and what we have to do is we need to examine the patient properly, look for dermatological condition, because majority of the time scalp itch is due to a dermatological condition itself. Once you examine the patient and you find out there is no dermatological cause, then we need to look at other causes like the systemic, neurologic, and the psychogenic causes. Systemic causes, yes, just like generalized pruritus, you could get scalp itch only, especially in chronic renal failure, cholestasis, and other systemic other conditions, reticular malignancies like lymphoreticular malignancies like lymphoma and things like that, where you can get itching on the scalp. Usually the itching in these conditions are actually generalized, but we know that in these conditions, itching can occur in certain areas of the body, like the scalp. And once the itching is more in these areas, people tend to think that they have itching on the scalp. And then you have neurological. Neurological is also systemic, but it is classified separately because the treatment of neurological itch is different from the treatment of the other systemic itch. Neurologic itch can occur in diabetes, where you have small fiber neuropathies, and you can also have it in nerve injuries. You can have it in herpes, post-herpetic itch. All these are neurologic itches, and the treatment for neurologic itch is different from systemic itch. Coming to the psychogenic itch. Psychogenic itch is not a waste basket sort of diagnosis. It's not that you don't have any other diagnosis for the itch on the scalp and you make a diagnosis of psychogenic. It's not like that. And it is not a diagnosis of elimination also. You don't find a cause, you try to eliminate all the causes and then you make a diagnosis. It's not like that. Psychogenic itch has got certain specific features. They're usually associated with other psychological or psychiatric disorders like depression, anxiety, obsessive compulsive disorders, and things like that. So these are all the conditions that the patient comes with scalp itch. Now we look at the cosmetic concerns. We humans have not decided what we want. Whether we want oily hair, we want dull hair, we want wind-blown sort of hair, you want waxy hair. Some people want long hair, some people want short hair, some people want a clean shave, some people want a long beard, some people want a design beard, and we are not still decided what we really want. So people come, one fellow comes with, I have dry hair, the one fellow comes with, I have oily hair, and so on. So these are all cosmetic concerns for the patient. And other things they come for is frizzy hair, split ends, procedure damage. After a procedure, they develop some damage to the hair shaft. And some people come with which shampoo to use, which conditioner to use. Do I need to use oil on my scalp? All these concerns we need to take care when these patients come to us. Finally, I would like to say a few words on the hair shaft disorders. Hair shaft disorders are disorders of the hair shaft itself. What if there is a damage to the hair shaft? That is called a hair shaft disorder, and it could be classified into hereditary and acquired conditions. Now, if you look at the hereditary conditions, we have two types of, it is classified into two types. That is the hereditary hair shaft disorders, which have increased fragility. That means they break off very easily. And we have another set of conditions, which are hair shaft disorders, which are hereditary, and they don't break off easily. And the ones that have increased fragility are Trichorrhexis Nodosa, Pili Torti. I'll just come back to all these terminologies a little later. Monilithrix, Trichoschisis, Trichorrhexis invaginata. The ones that have less fragility or no fragility are Pili trianguli, canaliculi, woolly hair. I have not included all the conditions here, just the important conditions. Okay. And the acquired ones, due to maybe bubble hair, where there is air trapped inside the hair shaft, or you could have Trichorrhexis nodosa, which is acquired. Not only Trichorrhexis nodosa can be hereditary as well as acquired, and Trichonodosis. Now, coming to the hereditary hair shaft disorders with increased fragility. The first one we will talk about is the Trichorrhexis nodosa, where you see the hair shaft fractures appear as nodules. They're actually fractures, but when you look with the naked eye, they look like nodules on the hair shaft. So when you see a nodule on the hair shaft, it's difficult to make a definite diagnosis by just looking at the nodule. So most of the time, you end up in doing a dermoscopy or a microscopy to identify what that nodule actually represents. In this, what you will see is, you will see as if two paintbrushes are thrust together. That is the appearance you see in Trichorrhexis nodosa. Trichorrhexis nodosa can be congenital as well as acquired. So in the congenital Trichorrhexis nodosa, what happens is there is breakage, or the nodules are more of the proximal type, near the scalp. So, and the hair breaks off near the scalp. And it may be seen in, it may be seen just like that, or it may be seen associated with other conditions like the Nethertons and the trichothiodystrophy syndromes. So this is about Trichorrhexis nodosa, where you see the hair starts breaking off. There are nodules on the hair shaft. The hair shaft hairs break off, and when you look under the microscope, you will see this two paintbrushes thrust together appearance. Coming to the next disorder or the hair shaft defect is Pili Torti. Pili Torti is actually twisting of the hair. Twisting of the hair at about 180 degrees, and there is flattening of the hair shaft. Flattening of the hair shaft with twisting of the hair shaft. That is what you see in Pili Torti. And the hairs are easily broken and they do not grow long. Menke syndrome is one of the conditions where you will see Pili Torti. So whenever you see Pili Torti, we should also be, it may be just congenital without any syndrome at all. But when you see this, you should always be looking at other features of Menke syndrome. And these people or these patients have depigmented hair other than breaking off. They have light colored skin, they have mental retardation, neurological defects, and so forth. And it is thought to be due to a defective copper metabolism. And many of these patients die by about 3 years of age. So it is a very serious condition. It needs to be identified early, and there's nothing much you can do about it. but at least you can tell the parents the prognosis and other things. And this Menke syndrome can have not only Pili Torti, they can have other hair shaft disorders like Trichorrhexis Nodosa and Trichoschisis also, along with this twisting of the hair of the Pili Torti. Next condition I would like to talk on is the Monilithrix. Monilithrix is otherwise called as beaded hair. It's an autosomal dominant condition. And again, the hair breaks off as soon as it emerges from the ostium. And this picture that you're seeing about this child's scalp is the similar picture that you will see in many of these hair shaft disorders with fragility. So whenever there is fragility, increased fragility, the hair breaks off as soon as it starts growing, even before it is 1 centimeter or half centimeter, the hair starts breaking off. So the picture in all these hair fragility conditions will almost be the same, except when you look at the microscope, you may be able to find out the different actual shaft defect. Now, these beads, when you look at the beads, you can just see these beads here. The beads, the bulged portion or the beaded portion is actually the normal diameter of the hair shaft. And the thinner portion is actually the narrowed part. That is actually the defect. The beaded part is actually normal in this. There is another condition called as pseudomonilithrix, where you get beaded hair, but it's not which looks like beaded hair, but the bulged portion is actually the defective part. It is actually flattened hair. The hair is flattened in that area, and it looks like a bead, and that is the defective part. That is pseudomonilithrix. In this, here the bead is the normal thing, and the constricted portion is the defective part. Trichoschisis is fractured hair. There is a clean fracture in area of focal cuticle absence. There is cuticle absence and a clean fracture. And one shaft itself, you may see multiple fractures. And this sort of hair is usually seen in a condition called as trichothiodystrophy. It's an autosomal recessive disorder, and it shows trichoschisis. Other features of this syndrome include photosensitivity, ichthyosis, low IQ, short stature, and recurrent upper respiratory tract infections. And one of the characteristic features that we see is polarized microscopy, you can see the tiger tail appearance. That is what you're seeing here, the tiger tail appearance. Once you see that, you can make a definite diagnosis. Trichorrhexis invaginata or bamboo hair, otherwise called as bamboo hair, is the diagnostic marker for Netherton's disease, which is an autosomal recessive disease. The hair is short, brittle, and lustreless there, and it is also associated with ichthyosis linearis circumflexa, and also with ichthyosis vulgaris, atopic dermatitis, erythroderma. All these conditions mixed together, and the patient is really sick and always having a erythroderma sort of feature. And once you look at the microscopy of this condition with the hair, you will be able to see the ball and socket sort of appearance, or the bamboo hair sort of appearance here. What you're seeing here, you can see the arrow here. And or once the distal end of the ball and socket falls off, you may be able to see the golf tee appearance of the hair. What you're seeing, that is blue circle, that is the golf tee appearance. That's fallen off already. So this is Trichorrhexis invaginata, or the bamboo hair. Now coming to hair shaft disorders with less or no fragility. You may not have hair shaft problems without fragility. They have less fragility. Now these people are able to grow hair slightly longer than the ones we saw earlier, where we have only very short hair which breaks off very easily. Now this is a condition called as Pili trianguli at canaliculi. It means that the cross section is triangular and there is a groove or a canal in on the hair shaft. So there's a triangular cross section with a canal or a groove in the hair shaft. This is one of our patients who was referred from the pediatric department, and they came to us. They had come for some other problem in pediatrics, and they were referred to us. On seeing the hair is something like as if the hair is made of plastic, and it's called the spun glass appearance of the hair, and something like nylon or plastic the hair feels like, and the syndrome is called uncombable hair syndrome, and these are autosomal dominant, and usually the hair is blonde, frizzy, and it cannot be combed flat. So always the hair looks like it is uncombed. Even if you comb it, it will stand up like this on. And this patient actually didn't want any treatment from us. They said, just leave the child alone, because the elder child had the same problem. And by the time 12, 13 years, the child was normal. So they don't want us to do anything. And they were not willing for any investigation. Then they went. And these people all improve with age. Woolly hair, again, the hair is coiled. It's one of the most commonest of the hair shaft disorders. And you see that the hair is coiled, around 0.5 centimeter diameter coils are seen, and they're very close. Coils are quite close together, and the hair does not grow long not because it breaks off, but because the anagen in this condition is truncated. So there's a very short anagen, so the hair doesn't grow very long. And here also combing is slightly difficult because of the coils. Autosomal dominant and recessive varieties are there. One thing to note is the recessive varieties are associated with syndromes like the Carvajal syndrome and the Naxos syndrome. The Carvajal, and both have palmoplantar keratoderma. So when you see a woolly hair with palmoplantar keratoderma, you must be looking at one of these syndromes, which can be associated with, in the Carvajals, you have the left ventricular cardiomyopathy, and the Naxos syndrome, you have the right ventricular cardiomyopathy. So you must have an evaluation of these patients by a cardiologist. The hairs usually darken and become less curly as age advances. So these are many of these conditions. All these conditions actually start improving a little bit, at least as the child grows older. It's not like they don't, in woolly hair also, when the child is born or a little after that, when they start getting this woolly hair, the hair is very little. And after some time, the hairs start growing, and even though they don't have normal hair, it will tend to improve as the child ages. Now coming to the acquired hair shaft disorders. The acquired hair shaft disorders, bubble hair is usually seen because of hair trapped inside the hair shaft. And this occurs in only predisposed, all people don't get it, only predisposed individuals after heating of wet hair. The wet hair, when it is heated between the heating tongs, or when it is blow dried on very high heat, that is the time you start getting these bubble hairs, and it causes breaking off. So that is the problem with bubble hair. Acquired Trichorrhexis Nodosa is caused by external physical or chemical factors, factors like cosmetic procedural things, and physical factors like rubbing, heating, all those things. And of course, weathering. Weathering is also another factor that produces Trichorrhexis nodosa, especially when there is a dry weather, when the cleaning is not good, when the sunlight exposure is heavy, and things like that, which cause weathering of the hair, can also produce Trichorrhexis nodosa. And these tend to break off at the nodules. In acquired Trichorrhexis nodosa, it is usually the distal end that produces the nodes, and that is called distal Trichorrhexis nodosa. Trichonodosis, again, true knots along the hair shaft occur, We do not know why it occurs. Sometimes there is a single knot like this, what you're seeing here. Sometimes there are even double knots. Actually, the reason why they are formed is not known. Usually seen, they appear as nodules, just like your Trichorrhexis nodosa or other beads or whatever, just nodules on the hair shaft. And they need to be looked under the microscope to see the actual knotting of the hair in these patient, in this hair. And it is said that long hair with which are curly are predisposed to this sort of nodosis or knotting of the hair. So with that, I think I have completed my presentation, and I think I can pass back the thing to Dr. Crichton. Shall I stop sharing?
Yeah. Thank you, Dr. Abel, for your very good overview of the hair and its disorders. And for postgraduates, you have to work from this point onwards. He has given an overview, and each condition which he has described requires a little more study. For example, Trichorrhexis nodosa. What are the conditions? How can you manage Trichorrhexis nodosa? And what could you expect in patients who are having Trichorrhexis nodosa like that? And most of the genetic conditions, some of the genetic conditions improve by itself. That also should be known. So unnecessary treatment should not be given. And you should not claim that the appearance after some treatment is due to your treatment. So a clear idea of what is happening to hair after, I mean, in conditions like acquired, congenital conditions. So we can treat in a better way, or at least we can give a good advice to the patient so that their spirit will be much more when they come with and the parents, especially when the children are brought and the child is having some hair disorder, most of the parents are upset. But if you say that in due course their hair will grow almost normal, then they will be happy. So the postgraduate should learn much more about hair disorders. And not only that, the hair disorder by itself is a clue for a lot of systemic disorders. For example, loss of hair happens with thyrotoxicosis. And you just look at the eye or the goiter, then you can quickly make a diagnosis that the patient is having thyrotoxicosis. So with these few words, I thank Dr. Abel for a very good presentation on hair disorders and overview. Thank you, Dr. Abel. The present and pleasant duty is to introduce Dr. Murugusundram. Dr. Murugusundram is a well-known trichologist. He is one person who is instrumental to make the branch very vibrant and known to many of the dermatologists. Earlier, all the dermatologists treat hair disorders, and there is no specialty in India. But some 15 years ago, Dr. Murugusundram has decided that he will specialize in hair disorders, and he has started the Chennai Skin Foundation and Yesudian Research Institute, where the emphasis is mainly in hair disorders. And lately, after 1 or 2 years of this foundation, he started an international journal of trichology. This is a very important journal as on today. There are not many dedicated journal of trichology, and we are very proud that it is from India. The Trichology journal has come, and Murugusundram is well known all over India, and he is very much familiar to all the dermatologists, and the younger dermatologists should also know that he is very much interested in trichology. And if you want to know more about trichology, you can have his contact, and you can converse with him. And with this, I pass on to Dr. Murugusundram.
Thank you so much, sir. So that is the trichology team. I think the ancient trichologists are of our ancestors, and you can see how keenly they are examining the scalp, and even without a trichoscope, with their keen eyes, they are examining the scalp and the hair. So trichology is not something new for us. It is present in our genes. Trichology is a branch of medicine concerned with the hair and scalp. Trichology is a study of structure, functions, and diseases of the hair. So only a dermatologist can be a true trichologist. That was the slogan of the first conference, and we should call ourselves as dermatotrichologists. So we should understand that trichology is our science, and we should never let it to the quackery. Trichology has become a subspecialty. Now it has become a super specialty because of the increasing aesthetic consciousness, increasing number of patients, expanding field of research, fascinating facts, interdisciplinary overlap, close to dermatology and internal medicine from trichology, and most importantly, to abolish quackery. And why should you diagnose hair disorders, and why should we start a hair clinic along with a dermatology clinic? Because often hair loss is a singular symptom, one symptom with complex disorders. Every patient complains of hair loss, but the cause for hair loss and the type of hair loss is different. They may appear simple, but they are difficult to diagnose. They demand special attention because the patients are very anxious, and they need complete evaluation because an accurate diagnosis and a precise diagnosis will give you clues to treat appropriately. So Johann Wolfgang Goethe once said, "What is hardest of all? That which seems most simple to see with your eyes, what lies in front of your eyes only." So what seems very simple may become very complex, and what seems very complex may be very simple. Raymond Seberot was the first trichologist and who started the hair and scalp clinic. We all remember the Seberot Sagar. In an approach to a hair patient, or in approach to diagnose hair disorders, the most important is history taking. William Osler once said, "Listen to the patient. He is telling you the diagnosis." There are three phases in the management of a patient. The first is diagnosis, second is diagnosis, third is diagnosis. This art of bedside diagnosis is very important, and that is what is going to be the essence of my talk today. So first, you make a subjective assessment by keeping a record of everything. Have a questionnaire of your own questions, a set of questions. Take a detailed history and analyze and evaluate. Listen to the patient very patiently because he may be telling you the diagnosis. Consider all the trivial symptoms. Primary complaint could be hair loss, but the secondary complaints are very important, which are going to help you in diagnosis, like scaling, crusting, itching, the pain, the trichodynia, which may point out to sensitive scalp, feeling of insects crawling, that may be a psychological hair loss in elderly, and early graying, like so many secondary symptoms, secondary complaints may give clues to what you are seeing at. And keep talking about the hair grooming habits, the hair cleansing frequency, the nature of cleanser or the shampoo, and how they dry the hair, and how they use the hair dryer, and how they oil, the nature of the oil, the hair and scalp before and after. And you all know about Muddichud from Kerala, and how they apply oil on the wet hair, and they develop this fungal infection on the hair. And oil massage is very popular again in Kerala, and oil massage can lead to a lot of problems. I'll show you some photographs. Hair setting creams, gels, sprays, whether how they comb, whether they comb on the wet hair or the dry hair, or the nature of comb, whether it is broad-toothed or narrow-toothed. If it is a plastic comb, that can also produce static electricity. All these small things, very trivial things, can have a very great impact on the diagnosis. This is one of our patients who had a simple diffuse hair loss, but it was irritated by hot oil, and she applied hot coconut oil mixed with some herbs, and then she started vigorous combing with a very dramatic metal comb, and she developed scarring alopecia. You can see the scarring alopecia over here. This is a hot oil comb alopecia, which is a very important thing which you would have missed if you don't take the proper history. And hairstyling habits like parting, whether they take central parting or side parting, whether they do back combing, that is the traction alopecia, frontal, parietal or occipital, and plating, all these are important. How? Like this patient had traction style alopecia, and she developed all these traction folliculitis over the scalp. And surprisingly, when we did the biopsy, it was a scarring alopecia. So everything cicatricial marginal alopecia can be all due to traction. So this is a very important entity, and traction alopecia can lead to cicatricial marginal alopecia. So this again is a very important diagnosis which you pick up from history taking. And hair parlor procedures like hair dyeing, hair coloring, both are same. Bleaching, the frequency, duration, nature of the dye, allergic reactions, hair straightening, waving, curling, physical or chemical frequency in herbal parks and spa treatments. There are numerous procedures people undergo, and all these can have impact on their hair loss problem. This is a patient who has colored the hair and with black henna, that is Kali Mehendi, and he has developed the secondary scarring alopecia. If you see the histopathology is of lichen planopilaris, it's a secondary scarring alopecia due to the hair dye. It is a early scarring alopecia and potentially reversible if he stops the usage of hair dye. This lady has gone to a parlor for hair straightening. You can see the nice flowing hair, which is shiny. But she came running to my clinic with some patches, scary patches on the scalp. And this is because of the chemical straightening, which has produced follicular scarring. This is again a scarring alopecia due to a beauty parlor procedure of chemical straightening. So this again, if you are good at history taking, you can identify it, and you can identify this and treat this effectively. And hair adornments like hair bands, hair clips, rubber bands, traumatic alopecias can be a secondary feature of this. And usage of flowers. We have seen a lot of Tinea capitis and Tinea amiantaceae in flower vendors when they carry these wet flowers on the scalp, and also when they keep wet flowers like adornments on the scalp. The UV gel sprays, fragrances can induce photo-aggravated alopecia. In fact, even androgenetic alopecia is considered to be a photo-aggravated alopecia. Vermilion. The Hindu women have the habit of applying vermilion on the center of the forehead, where they take the parting, the center parting. They can develop allergic contact dermatitis over that area, and they can develop a patchy alopecia. Sometimes that can also become a scarring alopecia. Tight cap in both in Hindu women and also in especially the Muslim girls, Islamic girls, they develop this pityriasis amiantaceae. There is a big paper which is done by one Dr. Abel in Turkey, of pityriasis amiantaceae in children who are advised to use this tight scarf when they come to the madrasas. And dandruff is a very important aspect, because dandruff can cause perifollicular inflammation, which is the first event in the androgenetic alopecia, as well as diffuse hair loss. So the patient perspective of dandruff is very important in the history and what treatments he has taken, because many patients use a lot of herbal treatments and they use a lot of parlor procedures for treating dandruff. Symptoms like itching, scaling, and oily scalp can also point out to dandruff. They may not believe that they have dandruff, and there is one big myth called dry dandruff. There is nothing called dry dandruff. You have to educate them that dandruff means only oily scalp, and there is nothing called dry dandruff. If they feel that there is an entity called dry dandruff, they may apply oil on the scalp and they may aggravate the dandruff. So most of them who deny having dandruff can reveal dandruff on examination, just with a naked eye or with a digital macro photography or with trichoscopy. So this lady had alopecia due to dandruff alone. She had itching and scaling in the scalp and oily face, itching and scaling of the eyebrows. She not only had diffuse hair loss on the scalp because of dandruff, she also had eyebrows alopecia due to dandruff. So environmental factors like tropical weather, sweating, which can aggravate dandruff, temperature, unable to cleanse scalp because of the cold weather, and UV exposure and pollution, the perifollicular microinflammation, usage of helmet. which is a big myth, and patients do not use helmet and lose their head instead of for saving the hair, and whether helmet can cause pressure alopecia or whether helmet can aggravate dandruff and pityriasis amiantaceae. Specific questions are very important because menstrual cycle is very important, because a woman always, the most commonest cause for hair loss in a woman is iron deficiency. So menstrual cycle is important. When they have menorrhagia and they have chronic anemia, that could be the only cause for hair loss. And in men, it's important to elicit the sexual and fertility treatments, because they may blame you for giving finasteride or any other alternative for their infertility, which may not be the cause, which may not be the real cause, because the usage of finasteride or sapalmito does not lead to reduction of DHT in the testicular level. It reduces DHT only in the hair follicular level. In children, premature menarche and precocious puberty also has to be considered. Medical history is important because we know that telogen effluvium can be due to recent systemic illness. Endocrine disorders like thyroid disorders and diabetes mellitus, pituitary and ovarian disorders can lead to hair loss. And chemotherapy, the usage of drugs and the history of drugs, all the list of drugs have to be taken. That is all very important. And list of the dermatological disorders also can be most important in diagnosing the hair disorders. And most important is the nutritional status. So the most common cause for hair loss in a woman is still malnutritional alopecia. And also in children, it is the malnutritional alopecia. So this college girl who lives in the hostel presented with diffuse hair loss, almost like female pattern hair loss. The hair, there was a lot of pigment dilution and there was a lot of hair breakage also. And when we investigated, the ferritin level was very low, the iron was very low, the calcium was very low, and the protein level was very low. Vitamin B12 was low, vitamin D was low. So it is a case of malnutrition alopecia. With supplements, she did very well. So in women, it could be very tricky. Like many malnutrition alopecias may be misdiagnosed as female pattern hair loss or diffuse alopecia areata. So malnutrition alopecia is the first and the most common cause in a woman. First rule out malnutrition alopecia and then go for other conditions. So this is one of our patients who had taken albendazole for a suspected parasitic infection of the brain. And for 21 days, she was given albendazole. She lost the hair completely. And once albendazole was stopped, she recovered all the hair that is lost. Sorry. So stress could be the cause, like in occupational stress, personal stress, educational stress is very increasingly important, and financial stress. And in every patient of hair loss, stress is a common denominator and points to specific hair disorders. And I used to jovially say that worry about hair loss is the commonest cause for hair loss. Dietary habits like dieting, skipping the breakfast, and hyperglycemic diet could be the cause for hair loss. Smoking and alcohol can never be ignored as causes of hair loss. They are most important causes. This is one of the patients who had stress, and she lost her parents during a bomb blast, and she developed this alopecia, almost like an alopecia totalis, and also marginal alopecia, clearly due to stress. There is a new entity called ADAFs, acute, diffuse, and total alopecia of the female scalp, most common in the female scalp. And this is a variant of alopecia areata, which responds very well to one injection of triamcinolone acetonide intramuscularly. So this is ADAFs, acute, diffuse, and total alopecia of the female scalp. So this is ADAFs, and you see the histopathology is also favorable for alopecia areata. It's a type of diffuse, new subtype of diffuse alopecia areata. So 10 minutes of history taking is equal to $1,000 of lab investigations. So never miss history taking. Then you go to the objective assessment. The examination, you see, touch, feel, count, and then pull. So seeing is presentation, touch is morphology of the scalp, feeling is morphology of the hair, counting is number of hair shed per day, and the pull test, and look through by photography and trichoscopy. So the duration of hair loss is very important. By this feature itself, you can narrow down the cause for hair loss. If it is a rapid hair loss, you are seeing something like acute telogen effluvium, alopecia areata, or diffuse alopecia areata, or anagen effluvium, or sudden acute stress, that is ADAFs. If it is gradual duration, that is more than 6 months, then you are seeing something like androgenetic alopecia, or chronic telogen effluvium, or malnutritional alopecia. So if it is the eyes do not see what the mind does not know. So with all these background information of the causes of androgenital alopecia and all the types of hair loss, you can easily follow this algorithm. If it is a diffuse hair loss, and if it is a patchy hair loss, then if it is round, it is alopecia areata, and if it is round and reticulate, it is alopecia areata. If it is triangular, it is congenital temporal triangular alopecia. If it is linear, it could be trichotillomania or trichotillomania. And if it is marginal and bizarre, then it could be euphiasis or traction alopecia. If it is a bizarre patch, it could be trichotillomania, reticulate alopecia areata, or scarring alopecia. If it is a patterned hair loss, then it could be androgenetic alopecia, and if it could be chronic telogen effluvium, because you can get the bitemporal thinning in chronic telogen effluvium. And trichotillomania also can be sometimes patterned. It is called Friar-Tuck sign. Some children pull the hair to mimic their father's androgenetic alopecia, almost similar to grade 7 androgenetic alopecia you can get. That is also trichotillomania. In diffuse, if it is a diffuse hair loss, it could be telogen effluvium. It could be diffuse hair loss, which is a early feature of female pattern hair loss, or it could be diffuse alopecia areata, or most commonly the malnutritional alopecia of women, which is always diffuse hair loss. So you know the Hamilton scale and the Savin scale. This is a new type of the Korean classification, BASP classification, easier to follow and monitor. So this is the bitemporal thinning of chronic telogen effluvium. This is the linear alopecia of trichotillomania. Tiro means to rub and remove the hair. So the children with the palmar surface of the index finger, they rub the scalp and remove the hair, rubbing and removing. So this boy was pressurized by the mother to get high scores in the school, and then he started doing this because of the stress. So there is a disturbed child-mother relationship in every case of trichotillomania or trichotillomania. So this is a classical case of chronic telogen effluvium. The women come with a head full of hair and also handful of hair. So what you do is only reassurance. So all the hair that is fallen will regrow. So that is what is chronic telogen effluvium. You don't have to treat them. You just have to prepare them for the next cycle by improving the nutritional supplementation. Then you touch the scalp and you see whether it is normal, oily, or dry scalp. If there is scaling, there could be seborrhea. If it is crusting, there could be seborrheic dermatitis, scarring alopecia, tinea, or psoriasis. If there is pustules, it could be seborrheic folliculitis or folliculitis decalvans. If there is erythema, it could be lichen dermatitis, lichen planopilaris, or discoid lupus erythematosus. If there is lichenification, then the end-stage LPP or pseudopelade, end-stage LE, or even trichotillomania and scarring. Then you feel the hair, feel the diameter of the hair, because the hair diameter diversity can be an important feature of male pattern hair loss and female pattern hair loss. Brittleness of the hair, the shine and luster of the hair, texture of the hair, color of the hair, bounce and waviness of the hair, all can be examined by feeling the hair. Then you count it, because the number of hairs that is fallen, you should know the correct count of it. Sometimes patient may bring in all the hairs that is lost by all the family members, and that could sometimes include the pet's hair also. So ask them for a proper daily count, and ask them to bring it in different pouches and label them, and then do an accurate count of it. The approximate values can be false positive, and they can be exaggerated, and sometimes they can include the body hair also. So if the hair shedding is less than 30, it could be androgenetic alopecia. If it is more than 100, it could be acute diffuse alopecia areata, acute telogen effluvium, anagen effluvium, and severe malnutritional alopecia. If it is more than 30 and less than 100, it could be chronic telogen effluvium. So the number of hairs shedding, the count is very important. That itself can give a clue about the diagnosis of hair loss disorder. And this is one easiest and important simple test with which you can have an accurate count of the hair shed. So ask the patient to sit in front of a light colored cloth and vigorously stroke the scalp for 60 seconds. And then number of hairs shed that can be counted within that 60 seconds. So this patient has lost about 90 hairs, which is less than 100 hairs, which is quite normal. But this could be alarming to the patient, because more than 30 hairs can be considered as severe hair loss by the patient. But you have to just give the reassurance and see whether it could be just telogen effluvium or associated with androgenetic alopecia, and then treat them. And this 60-second hair count can also be used as a tool to monitor the progress of the treatment. We use the 60-second hair count to monitor the progress of treatment in this patient, and he seen a number of hair shedding is gradually coming down. Initially, it was 90, then it was 35, 28, and 8. The pull test is a very easy method. Just pull about 20 hairs, and if you get more than 10%, it is a positive pull test, and the hairs can be examined against bright light. And I will tell you how you can do a trichoscopic trichogram with just this pull test. When you do the pull test, the diagnosis is almost full. If it is negative, then it is androgenetic alopecia. But if it is positive, that is more than 2 out of 20, and if all the hairs are telogen, then it could be telogen effluvium or nutritional malnutritional alopecia. If you have dystrophic hairs, then it could be alopecia areata or drug-induced. If you have anagen hairs, it could be anagen effluvium, loose anagen syndrome, or due to homeopathy. So the most important instrument in dermatology is the naked eye, but sometimes even beyond the naked eye, in trichology especially, you may require a simple tool called trichoscope. So the digital macro photography, trichoscopy, and dermascopic trichogram we'll see now. So this is the olden days. We used to use some scopes and then connect that to the television monitor and then examine, which sometimes we can have some false positive results. But now with the Android phone, which everybody is having, we can have a very good information about the scalp. See, this is a normal patient where we have taken the digital photography and the macro photography, which shows that there is a lot of dandruff, the sebaceous hyperplasia. In fact, the hair diameter diversity also can be easily studied with this digital macro photography alone. This is a trichoscope. Trichoscope is the magic wand of the Harry Potter, not the HARRY, HARRY. Trichoscopy is the hair and scalp dermascopy using a handheld dermascope, epiluminescence handheld microscopy. You can study the scalp morphology like sebum, scaling, crusting, follicular clogging, and follicular plugging. Follicular units can be clearly studied. Hair diameter variability can be easily studied. It's the most essential, simple, and an inevitable handy tool for every dermatotrichologist. Although many magnifications are available, 20x magnification is the best for the practical trichoscope. You can see the scalp morphology, follicular morphology, the perifollicular signs like peripilar signs, the violaceous hue of scarring alopecia, LPP, the hair morphology, the hair root morphology. Everything can be easily studied with the trichoscope. The diagnosis, disease progression, evolution of treatment and monitoring, everything can be done with the trichoscope. So this is the violaceous color of lichen planopilaris, very easily seen. You can see the perifollicular plugging, the violaceous color. With the trichoscope, you can easily diagnose lichen planopilaris even without doing a biopsy. This is the sebum. Proliferation of sebum by trichoscopy. The sebaceous hyperplasia by trichoscopy. And you can see the scaling of little beyond the sebaceous hyperplasia, you get the scaling, early seborrheic dermatitis, and you can see the crusting of seborrheic dermatitis. You can see the loops of the capillary loops of psoriasis. You can see the classical features in DLE, and you can also mark trichoscopically, you can mark the site, and then if you do the biopsy at this site, you will get the correct histopathological evaluation of the scarring alopecia that you're looking at. This again, the folliculitis decalvans, you can see very clearly with trichoscopy. The tufted folliculitis can be easily seen with the trichoscopy. The atrophic scalp, where you can do the biopsy and you can correctly get the histopathological picture. And this again, pseudopelade, where it is completely in-stage scarring alopecia, the honeycomb pattern. The exclamation mark hairs of alopecia areata, you can see the classical exclamation mark hairs. The exclamation point hairs, where the area, the hair is broken just above the hair root. You can see the exclamation mark hairs, again a classical sign of alopecia areata. You can see the cadaverized hair in severe alopecia areata. The monomorphic white dots, sometimes you may not see any classical signs of alopecia areata, only the monomorphic white dots may be present. That also can be seen only with trichoscopy. You can see the monomorphic white dots in the pigmented scalp, classically by trichoscopy. Because monomorphic white dots can be the only feature in alopecia areata incognita, and also in diffuse alopecia areata, and also in acute diffuse and total alopecia of the female scalp. The sebaceous prominence, monomorphic white dots, how you differentiate between these two. And the hair diameter variability, you will see the vellus hairs and the terminal hairs. This is a classical feature of female pattern hair loss, because it's very often very difficult to differentiate between the diffuse hair loss and early female pattern hair loss in a woman. So this trichoscopy and identifying this hair diameter variability becomes a handy tool. And based on trichoscopic features, you have a criteria and you can diagnose many hair disorders simply. This again the hair diameter variability and trichoscopy. This is the perifollicular brown halo, which is the earliest feature of androgenetic alopecia. You can see the follicular units very clearly, the frontal area, vertex, occipital and terminal. So this is very useful when you monitor the treatment progress. Follicular units, you can see all one hair per follicle. This is again the coiled hairs of alopecia areata, and especially trichotillomania, because they gently roll it and then just pull it suddenly. Trichotillomania, the classical sign. The broken hairs of trichotillomania. You can see the frayed ends of the hair margin also with trichoscopy very clearly. So you don't even need a microscope to examine all these disorders. Even hair shaft, this is the lichenified scarring area of the trichotillomania. Again, trichotillomania. You can see lice and nits very clearly with trichoscopy. This is the crab louse. You can see the perifollicular, the hair cast, which is a very important differential diagnosis of nits. You can even see the hair shaft disorders like Monilithrix, Trichorrhexis Nodosa, all with trichoscopy. You don't need a microscope for this. And based on the trichoscopic findings, you can again have a algorithm. I can send it to you. You can use trichoscopy for the monitoring of the treatment. See, this patient is improving so well, and this is easily monitored with trichoscopy. And when you show these pictures to the patients, they are really at once convinced. Similarly, in men, a very good progress after treatment. And this is again trichoscopic images correspondingly. So you can mark the area when you are doing biopsy for scarring alopecia. So you get the correct features in DLE. So trichogram, I will show you how to do a trichoscopic trichogram. That will be the last part of my lecture. A simple, reliable and rapidly diagnostic method. You just do a pull test and place the pulled hair on your prescription paper, and then cover the roots with the glass slide, and then examine under the trichoscope. If you get this anagen hair roots or like golf stick appearance, there is a small bend at the 20 degrees. The hair root is larger, and the hair root is the base is also broader, and this appears like a golf stick. Anagen appears like a golf stick. Then you see the telogen hair roots like a earbud or a club-shaped root. Like a earbud or a club-shaped root. There is no bend at this 20 degrees. Just above the root, there is no bend of 20 degrees. The hair root is quite straight and appears classically like a earbud. Catagen hair roots we often don't see. And dysplastic, like on hockey stick, because the peribulbar inflammatory infiltrate in alopecia areata destroys the hair root, and the hair root is partially destroyed and becomes dysplastic. So this is like a hockey stick, like a hook-shaped root. And when it is completely destroyed, the hair root gets cut over here, and there is already a coodability, and the hair appears like a rat tail or a pencil tip narrowing here. So this is dystrophic. So you can see the dystrophic hairs very clearly. So here the hair follicle, the hair root was there, which has been cut off. So this is a narrowing because of the peribulbar infiltrate, and this area it is cut off. So it appears like a rat tail or a pencil tip. This is dystrophic. The dystrophic and dysplastic hairs are classical signs of alopecia areata and dysplastic anagen in trichotillomania. When you get a telogen hair root pattern, then you are seeing telogen effluvium, postpartum nutritional alopecia, anemia, endocrine disorders, sometimes alopecia areata, diffuse alopecia areata, and alopecia areata incognito, and sometimes even androgenetic alopecia, because androgenetic alopecia can associate with telogen effluvium very often. When you get anagen hair root pattern, it could be drug-induced cytotoxic drugs, homeopathic drugs, chemicals, acute alopecia areata, traction alopecia, trichotillomania, loose anagen syndrome, and also in AIDS, trichopathy. Dystrophic and dysplastic hair root pattern is a classical sign of alopecia areata and sometimes even endocrine disorders. You get a mixed pattern, and then accordingly you should diagnose based on the mixed pattern. You can even interpret specific diseases like thyroid disorders, lichen planopilaris, trichotillomania, aromatic retinoids. All these can be, once you get start doing trichoscopy and trichoscopic trichogram, by experience you learn all this. So I already told you about this androgenetic alopecia. There could be associated telogen effluvium. In alopecia areata, dysplastic and dystrophic hairs are 75% pathognomonic. So you can see the coatability of hair. There is a narrowing of the hair just above the hair root. And here it is completely cut off. You can see the dystrophic hair root, coatability, and here it is dysplastic. So all the features of alopecia areata. So it is a very simple, reliable, fast and rapidly diagnostic, suitable for a busy dermatotrichologist. It is less painful, no need for many instruments and gadgets, can be done in any place. So the skin presents unequaled opportunities for the study of morbid process. That was said by Sir Jonathan Hutchinson. I would like to adapt it and say that the hair presents unequaled opportunities for the study of morbid process of the skin and the body and the mind as well. So very important to analyze and diagnose hair disorders, because you may be able to find out the internal problems of the body and mind. Please join the Hair Research Society of India, and also when you join the Hair Research Society of India, you'll get a free subscription to International Journal of Trichology. You can go to the websites, and thank you very much for the patient listening.
Thank you, Dr. Murugusundram. It's a wonderful talk. Thank you once again. And the postgraduates have learned a lot from your talk. And again, as for the previous speaker, I have made an appeal to the postgraduate. Dr. Murugusundram has given only an overview of this. So you have to build on these particular aspects of his, like history taking, history and examination, the touch of the scalp and hair. All these are important, and you have to plan the investigation according to the history and the examination finding. Just like a battery of investigation won't help to make a correct diagnosis. So with this, I think we have to close this session. Thank you, Dr. Abel, and thank you, Dr. Murugusundram, for your wonderful presentation. Thank you. Over to you, Naveen.
Isoswarma is proud to organize this academic session to facilitate deep subject learning in the field of dermatology. And the session on hair loss featuring an eminent specialist in the field, the part of series undoubtedly benefited postgraduate students. We extend our gratitude to our professor, Dr. Crichton, sir, for taking Glow platform to newer heights by taking initiative to invite eminent speakers like Dr. Abel Francis and Dr. Murugusundram. Postgraduates are requested to share the information about the forthcoming session with their colleagues so that they they too can be benefited from them. We extend our heartfelt thanks to Dr. Speakers, Dr. Murugusundram, Dr. Abel Francis, as well as our course director, Dr. Crichton sir, for their wonderful lecture. We also extend our best wishes to all the participants who enjoyed and benefited from the session. And Research Pharma is committed to continue the academic session forever. Thank you so much, Doctor, and have a nice day to all.
Thank you.